This is Michael Webster-Clark from the University of North Carolina at Chapel Hill. Today, I have the pleasure of presenting you with a video abstract on behalf of myself and my colleagues from the university on our original research article that is due to be published in Epidemiology in their January 2019 issue. The title of our work is Diagnostic Assessment of Assumptions for External Validity, an example using data in metastatic colorectal cancer. There is increasing interest from a variety of stakeholders in taking treatment effect estimates from studies, be they randomized controlled trials or observational work, and assessing whether those treatment effects can transport to target populations that didn't participate in the initial study. Unfortunately, the methods that have been developed to estimate treatment effects in external populations that were not a random sample of the initial study population do make the assumption that all important effect measure modifiers have been identified and appropriately modeled. This is analogous to the assumption of no unmeasured confounding that is necessary for internal validity of observational studies. Fortunately, we can actually use propensity score-based diagnostics and inverse odds of sampling weights to assess whether we think we have actually measured and appropriately modeled all important effect measure modifiers. In our paper, we describe how these diagnostics can be done and provide a test case using the bevacizumab or standard of care arm from the Horizon 3 trial of patients with metastatic colorectal cancer. We take this population and re-weight them to resemble a target population of 1,942 Medicare beneficiaries over 65 with metastatic colorectal cancer that were actually treated with bevacizumab in routine clinical practice. Both before and after this re-weighting, we compared survival in the trial population to survival in the Medicare population, both with hazard ratios and with risk differences at 6 months and 1 year. In our unweighted comparisons, the control arm participants had much lower mortality compared to the target population participants when they were treated with bevacizumab, with a hazard ratio of 0.72, representing a marked improvement in mortality. After we applied inverse odds of sampling weights, this hazard ratio was greatly attenuated and became much closer to the null, meaning that the survival was more similar and we were less likely to have violations of our assumptions that we had taken into account key effect measure modifiers. However, even after this weighting, hazards did not appear proportional. At 6 months of follow-up, mortality was markedly lower in the trial population than in the target population, a decrease of 7%. But this decrease did not persist at 12 months, where there was actually no difference whatsoever. In our specific case, these diagnostics suggested that directly transporting the treatment effects from Horizon 3 to the Medicare population would not have been valid, simply because the survival was too different when all effect measure modifiers were ignored. However, once we implemented our sampling model, we were most likely better able to validly transport these treatment effects on longer-term mortality to the Medicare population treated in clinical practice. We hope that researchers will start using this work and these methods to go beyond simply stating that they are worried that their results may not generalize or transport outside the study in which they were initially conducted. Thank you.